Alright, good morning everyone, or if you are with us online, good afternoon or good evening, depending on what time you're actually accessing this particular video. So, in this online lecture, what we're going to do is to recap some of the main concepts that we have learned in semester 1 and looking at how they actually join up together in order for us to sort of put together the knowledge base that you already have, because you've been doing it week by week, so you don't really sort of have an overarching view of what you've done so far. But hopefully after this summary sort of lecture, you'll be able to put everything together and knowing that have that moment where you go, okay, that's exactly what I've learned. And hopefully you'll be then able to use that to apply to your own clinical practice right now or in the future. After that, what we'll then do is have a little look at the summative assessment part, which is the assignment that I've actually given all of you to do. And looking at the question, looking at breaking down some of the sections that's required of you. And because I know that some of you have asked me, what is it that is really required for the assignment? What is it that I should put in, and what should I do for some of the articles? I'll just briefly go through some of that and then refer you on to some of the guides as well as the marking criteria that I've drawn up for you, so that you know exactly and you've got something concrete to actually refer to. So let's make a start. The key concept for this entire module is essentially about outcome measures and clinical measurements. So we have got this central theme of looking at an outcome measure that you want to use for your clinical settings. And the reason why we put it so generic is because we know that all of you come from different settings. You may be from neuromusculoskeletal, you may be from cardiorespiratory, or you may be from neurology, or you may be from some specialist discipline like, for example, cancer care or lymphedema management. That essentially means that the type of outcome measures that you use will differ across different areas. And so to actually go down and just narrow down to just one outcome measure or a few outcome measures would be too restrictive. And besides, if you look at, if you read the chapters that as we went through the different weeks, you realize that when you choose an outcome measure for the exact same outcome measure, when you use it in different settings, it will have a slightly different meaning as well because of the clinical population you're at. So, which is why you need to actually learn about some broader concepts, which I'll talk about in terms of the characteristics of the scores of outcome measures, and then being able to apply in any setting. Therefore, this skill is actually transferable. We went on to one of the very first lectures, and one of the very first concepts that you have actually learned is about the ICF, International Classification of Function. Just to have a very brief overview, we know that the ICF talks about bodily functioning structures, activities and participation, and how that leads on to a person's health state or well-being, overall well-being. And if someone has got dysfunction in any of these domains, it's called an impairment for the bodily functioning structures, it's called activity limitation, and participation limitation for participation. One thing that we noted is that, obviously this is the modified version of what it used to be. This is the version 2 of it. But one thing that we note is that sometimes impairments, limitations, and restrictions, participation don't actually correlate very well to each other. Okay? So just because someone has got an impairment does not necessarily mean that the person will have an activity limitation or participation restriction. Therefore, that has got implications for clinicians. When you actually look at someone, you cannot just look at the impairments, which physiotherapists are very good at looking. In fact, doctors, medical professionals are also very good at looking for impairments. But what we are less good at is looking at the activity limitations as well as the participation restrictions. A lot of times when patients come to you to be asking for your advice and to be treated, they are much more interested in resolving the activity limitation or the participation restrictions. So there's some sort of function they need to do, some sort of task, or some sort of role they need to play in society, that is why they come to you. Obviously, if you actually help them with the impairment, it may or may not lead on to an improvement in the activity limitations or the participation restrictions. So that's something we need to do. But then how does that then link on to outcome measures? Well, the thing is, in order to know exactly which domain has been affected, you will all need to know how to measure each one. Different types of outcome measures measure different types of domains, some quite mixed. And in one of your weeks, you will have noted that I've asked you to take one of your, a chosen clinical measurement or outcome measure, and then to actually map out to see whether it is actually measuring an impairment, a limitation, and restriction. And you realize that a lot of outcome measures that you've chosen really actually just measures impairment and limitation. There is very little that actually goes on to measure participation restriction, which is a bit of a deficit. But there are outcome measures out there that actually does that. What you need to do is then go away and look at complementary outcome measures and then use them in tandem so that we get a much more holistic view of what the patient needs from us as clinicians. And then we went on to something much more hardcore, where we went in and dived into things like measurement error. Okay? Now, measurement error is actually a very, very simple concept, but it is one of the keystone concepts of when we're looking at characteristics of outcome measures. When we talk about outcome measures, essentially we are talking about measurements. For those of you who are not very into measurements or into data analysis, this shouldn't be a big jumping block. It's a basic concept where we know that measurement exists. For example, if you were to measure the amount of water for you to put into your cake, to bake a cake, and to put it in your flour, when you use the mug, and if it's one of those calibrated mugs where you actually has got what's the volume of the water that you have, when you pour it in, occasionally you realize that depending on where you look, the volume actually changes very, very slightly. That doesn't mean that the water will shrink and expand just because you move your eyes away from it, but it's simply because of the meniscus effect, where at different angles you see different volumes being read off. That is what's considered as systematic error. It is a function of the meniscus effect. So therefore we have to standardize the way we actually read off the mark. But sometimes there are random errors. Random errors can occur anywhere due to a lot of reasons. But the main thing is that errors do occur, and we have to take that into account when we actually implement our outcome measures and then measure our patients, whatever concept that we are measuring or construct that we're measuring out of our patients. Now, out of that, we know that the measurements that we take contains the actual value that we are trying to get out. So imagine if you're trying to measure the functional ability of someone, within the score that you get from the questionnaire or scale that you use, it will contain the true value. However, within that, it will also contain some sort of error, whether it's from you administering the questionnaire or if it's the patient misjudging their own ability, that will be incorporated into that. So that's the main thing. Now, I won't go into the philosophical arguments of whether this is a positivist approach to measurement, or and therefore it may be that there is some doubts as to how it's being applied. What we are just going to assume is that all of us take this view that a measured value will contain both the true value and the error, and perhaps the philosophical debates can be left for another day. And then, after knowing that a measured value contains a true value plus all its error, we then go on to look at some of the properties and characteristics of scores when we use an outcome measure. The main thing that has been covered in the readings that I put forward to you is mainly test, retest reliability. Test, retest reliability is the consistency at which a score from an outcome measure is being collected if you do exactly the same outcome measure at different times, whether it's different times of the day or different days of the week. And assuming that the person hasn't changed in terms of their functional outcome or the status of their health, that these two scores from these two timings will be roughly the same, or as we say, fairly consistent. And that is the main thing that we've been looking at throughout this entire module in semester 1. Of course, related to that, but perhaps touched less on, is looking at the actual properties of the questions that's been asked within the outcome measure, assuming that you're using a type of scale or questionnaire. But this is less covered. It's called internal consistency reliability, where within the questionnaire itself, within the questions, because the questionnaire is trying to measure one construct, so therefore, this reliability actually sees whether the questions are all asking about the same thing. If they are not, then obviously the reliability will be poorer, and therefore we aren't so confident about that particular questionnaire or outcome measure measuring the construct that we're interested in. Okay. And then there is one more type of reliability that we haven't actually talked very much about because it's probably not as relevant to us at this point in time. It's called inter-rater reliability. Inter-rater reliability, as some of you would already know, is the consistency of between maybe two therapists or two clinicians when they use exactly the same outcome measure to measure the same patient at the same point in time. How much do they differ in terms of their scoring? Okay, and it can sometimes differ quite a bit. So, but the reason why that's probably not been touched is because we are much more concerned about one clinician using the same outcome measure within the same service consistently over time. But obviously, if within that service, if the same patient if the patient can be seen by several clinicians over a period of time, then inter-rater reliability then becomes more of an issue. But usually, if you look at research studies that looked at reliability, they will not just do test-retest reliability. Occasionally, half the time, they will also look at inter-rater reliability because it's also one of the important concepts that needs to be taken into account. Within the reading that I've given you, two main types of statistics comes out when we talk about reliability, especially for test-retest reliability. The first one is called intra-class correlation coefficient, or as the readings, the acronym for that's used is ICC. Okay, and if you have read some of the, if you already collected some reliability studies for the outcome measure you've chosen for your own assignment, you realize that the articles actually do use intra-class correlation. Okay, the interpretation of intra-class correlation is simple. It's essentially from 0 to 1 or 0 to -1. How you interpret correlation coefficients anyway. 0 meaning that there is very poor consistency or no consistency at all. 1 meaning it's very good consistency, and -1 is opposite good consistency. But usually it's between 0 to 1, and then you got in between. For test-retest, we tend to want to get a value of at least 0.75, okay, depending on which textbooks you read in terms of the cutoff threshold. Because anything less than that for a test-retest would be fairly poor. So test-retest tends to get very high because it's the same person measuring within a short period of time, hoping to get the same scores. Now, another thing about ICC is that it can be useful to know whether it actually differentiates between health states between patients. So let's say, for example, we've got a group of patients with a very good functional status on this outcome measure, and another group with average functional status. If the ICC is high, that means that the particular outcome measure is able to differentiate and be able to classify these two groups of patients and put them apart. Okay, if it's poor, it's much less able to do that. So it gives us some confidence that the outcome measure is able to help us grade the severity or the different grades of status, maybe for function or for some sort of construct that you're interested in measuring for these one huge group of patients but with differing abilities or severity of the condition they are actually having. The next statistics we use for reliability is standard error of measurement. It is a fairly simple statistics, even though it sounds horribly complicated. is essentially measuring the amount of measurement error that is inherent in your measurement. Okay, anything, it will give you an amount, and anything that is above this amount, anything below this amount tends to be due to measurement error. Anything above that is due to measurement error and due to some sort of other error or your actual true value. So for more details of that, you can actually refer back to the week where we talk about standard error of measurement. It's actually a very useful concept, even though we don't use it very often when we calculate some of these scores in the clinic, because we don't. We just don't. We don't take our calculator and calculate standard error of measurement. But it's a very important concept when you actually start to engage and try to choose an outcome measure for what to use within the clinic. Because if the outcome measure has got a very, very large standard error of measurement, then that means that it won't be useful at all in your clinic. It won't be useful for your clinical application. The reason for that is anything that you do, you have to get a very, very high score or large difference before you can safely say that the scores that you're measuring is not due to measurement error. Okay, so you want something, an outcome measure with a very narrow or a small error of measurement. When we talk about reliability, usually we then group its cousin concept, which is validity. Now, validity is a generic concept that talks about whether an outcome measure is actually measuring what it's supposed to measure. So, over time, psychologists or psychometrists have actually divided validity into its different types. For the reading that you had for semester 1, the three main types of validity are content, criterion, and construct. We can actually further divide that down into sort of subcategories or subtypes, but in the literature they tend not to say it as subtypes, but actually as a full validity type. For example, for construct validity, you can actually divide it up into what's called convergent and discriminant. And the difference between them is that if you have a reference standard outcome measure, which means that that's the standard, the reference that you compare it, the gold standard, and you've got a new outcome measure that is measuring a similar construct, then if they've got convergent validity, that means that the two are measuring about the same. So therefore, any scores in terms of, if we were using construct validity, we tend to use reliability scores and what's that? Correlation coefficients anyway. So the higher the correlation coefficient, the closer they are in terms of measuring the same concept. And then we got the opposite concept, which is called discriminant validity, where depending on the score, the two outcome measures can actually diverge and they are actually measuring something else. And you can actually design that. For example, you can choose an outcome measure that deliberately that doesn't measure the construct you're interested in, and then the new one where you are actually interested in measuring that construct. In theory, these two should not match up in terms of the scores, but if they do, that means that there is something wrong with the new construct, with the new outcome measure that you are using. Okay, and we can do all sorts of, we can divide them out into all sorts of different types of validity types. But just to bear in mind that they are not discrete categories on their own. Construct validity and criterion validity and content validity are all related. Okay? The reason why we have actually categorized them is because it makes much more sense to actually categorize them in our minds. It is just what humans are designed to do, to actually categorize them, and then it helps us with our understanding. But overall, it's been agreed in the general literature surrounding validity that all these are one general concepts, and then whenever you're measuring, you're trying to determine the validity of your outcome measure, it tends to be that you'll be measuring portions of these. But of course, your study can be geared towards and concentrating on more of any of these, sort of focusing on any of these specific aspects of it. Okay. Because we are using a lot of outcome measures for clinical application, therefore, what is important to us is not just about whether an outcome is measuring what it is, but we're also interested in whether can we then set a threshold to see whether a patient has improved or not. because that's very important, because if we are not able to measure if someone's improved, then that outcome measure is complete rubbish to us. So, which is why in the book, in Riddle and Stratford, it introduces two new types of validity, which I've not heard of, but I know the concept. They call it the cross-sectional validity, as well as longitudinal validity. They are slightly different. Cross-sectional validity essentially is in the same group as the validity types over here, where you're taking only just one measurement and at one point in time. Okay, we use that to determine either the baseline of a patient, of how well they are or how not well they are, or we determine whether at a second point in time how much they've actually improved. Whereas the idea of a longitudinal validity is that you are now comparing between several time points and determining if at these time points are they actually measuring a true improvement of your patients. Okay, and how confident are we at doing that? Which we will talk about in later slides, where we use certain statistical methods to help us determine our confidence in saying how much the patient has actually improved. Okay, now jumping straight into that, we've got a third and slightly more newer concept of properties or characteristics of outcome measure, which is called responsivity. In some other textbooks, there's a similar phrase, they call it sensitivity to change. They're exactly the same thing. Responsivity, which I find it very hard to pronounce, and sensitivity to change is exactly the same thing. So, but because it's much easier to use one word, I'm just going to use that. Now, responsivity, there are two types, which the first one is what is considered true change. Okay? And with that, we were looking at whether someone has improved or not. And then we were introduced to the concept of diagnostic test methodology, which I know is a very, very difficult thing to get our heads around. But think of it this way, to simplify it, think of it this way. Imagine we know that a patient has got comes in with a condition, okay? And after treatment, they may or may not improve. We do not know, the clinicians do not, which is why we need to measure them. But imagine the true state. So they may either have truly improved or they may not have truly improved. So they may have stayed stagnant. So which is why we have got this row over here which says that either the patient has really improved or not really improved. Okay, so that is what the patient has. Now, step out again. And now think of yourself as being the clinician. You only have an outcome measure. You can only determine whether the patient has improved or not by the outcome measure score that you have. And that's exactly what these two columns are actually saying. What it's saying is that based on the scores that you have, if it's a high score, pretend that if it's a high score means improvement and a low score means that it's not improved. You've got two states. One, the score says that the patient has improved, or the score says that the patient hasn't improved. Now, obviously, sometimes because you do not know the true state, the outcome scores can be based on, because of measurement error, you can be wrong. Therefore, there are two types of errors that can be introduced. One is if you improve, if the patients did not improve, but somehow or another your outcome measure says that patient has improved, that means that there's one type of error, isn't it? Or, if the patient has actually improved, but your outcome measure says that the patient hasn't improved, so that's a second type of error. Okay? Now, putting the errors aside, there are two states where your outcome measures can actually get it right as well. So imagine the state where the patient has really improved, and somehow or another your outcome measure accurately says that the patient has also improved. In that state where both your outcome measures got it right, this is called sensitivity. If you relate that to how you think about certain tests that you do for your patients, a physical test, and how, in terms of how accurate it is, you sometimes see in some of these papers talking about sensitivity of the test. This is what it's talking about. Okay, but that is more about diagnosing a particular condition or a particular disease. Whereas now we're not talking about a condition or disease, we're talking about whether the person has actually improved or not. So a type of improvement change. There is another type which is slightly opposite to what sensitivity is, where the person hasn't actually improved and your outcome measure truly actually accurately tells you that the patient did not improve. Now that is called specificity. Okay, so these are complementary ideas, and based on that we can actually do a lot of things. We can plot these things called receiver operating characteristics and then compare to see at which point the patient, at which point we can actually use it as a cutoff later on to use for us as a target goal to determine whether the patient has truly improved or not based on previous studies. Okay. Now with that, there are two related ideas. One is called the positive predictive value, and the other one is the negative predictive value. Now that is a very difficult concept for a lot of people. What it simply means is that based on the scores that you have and on what we do know about from past research about its sensitivity and specificity, how much confidence can you truly have in the outcome measured scores that you have about a patient? What is the percentage confidence you can have about saying that that person has truly improved or whether that person has not actually truly improved? Okay, so if the patient has actually improved on the scores, then you use your positive predictive value and calculate the percentage, and that is your confidence. So if it's anything like 75%, you are 75% confident that that person has actually improved based on the improvement scores. However, if the patient has not improved, then look at the negative predictive value. If the predictive value is about 80%, that means that you are 80% sure that really that person hasn't improved and you need to do something about it in order to make the improvement much more or get them to work harder or things like that. However, if let's say for example the predictive value is only about 52%, that means that it is not that you cannot be very confident whether the patient has actually not improved. There may be something wrong with your outcome measure or the way you administered it. There must be some factor, and therefore either you change the outcome measure or you actually remeasure them to determine whether there is a truly non-improvement. Okay, so things like that you can actually get very interestingly, which clinicians don't do because we just don't have the time. But it is possible if you have got just that little time to actually calculate that and be having a much more quantitative approach to determining whether an actual improvement or actual no improvement really occurred. So we talked very briefly just now about the target goals. If you were to set a target goal, we are again looking at sensitivity to change, which is also the responsivity. There are different methods of determining or setting target goals for the patient to improve. So imagine if you were to use a 6-minute walk test in terms of the distance that they travel. So you set a particular, how would you determine what distance would be appropriate for this patient as a cutoff point for them to say that they have actually improved about maybe 4 weeks later. There are several ways you can do it, as the reading that I've shown you has actually pointed out to you. You could use within patient comparison. In this case, for the 6-minute walk test, you can't, because you can't compare left and right, because you can't have half the patient walking normally and half the patient not walking normally. It is within patient comparison. It's much more useful only when, let's say for example, you're comparing sensation across left and right, or perhaps you're comparing range of motion between left and right. Okay. However, if it's a whole body system issue, then within patient comparison won't work at all. So then we have to use other things. Another very common method is to simply use normal or customary values, where a study has actually collected a lot of data from a lot of people and then set for different genders, different demographics, what are the cutoff points for the 6-minute walk test. So we can do that, or similar to the normal or customary values, we can collect a lot of data from a lot of people and then divide them according to demographics and then put them along the percentile. So we will have what is a normal, generally on average everybody's at this level. But then if you cross past that, you're at which percentile of the values and so on and so forth, how much better you are to the average or how much worse you are from the average. We use that a lot when we are doing pediatrics. For example, we are talking about birth weight, since birth weight, what is the weight of the baby now, and we use the, depending on whether using stage of development, and also what's that, ethnicity, as we can actually do whether your baby is actually above average or on the average, on target in terms of development, or below that. Because obviously if it's way below normal development, you have to do something. Maybe it's nutritional deficiency, or maybe there's not much stimulation in terms of its physical activity, and therefore you can then correct for that. So that's a very common one to use as well. But we obviously, there are a lot of other ways to do so. For example, we can use reference equations. Reference equation is when some researcher or a developer of an outcome measure has actually looked at the different variables, the different types of influence that will inform how a person may improve, and use that as a target value. So one very common area where reference equations are used are cardiac rehabilitation and pulmonary rehabilitation. The reason for that is because they use it to calculate a lot of the 6-minute walk tests, but also in terms of their target heart rate value as well. So they use reference equations to help them calculate that. And obviously we can also use the diagnostic test methodology, which we talked about previously in the previous slide, and we can use that to set our target values as well. But instead of using a change, we're now using just one value, okay? And within the reading of, I'm trying to remember which week was it. I think it's week 8 or week 9. You have actually done something like that, where you actually been asked to calculate and look at an article surrounding how you can set target goal values. And in between, we sort of had a break from the very sort of heavy-going sort of properties of scores or outcome measures, and we went on to look at how to perform literature search surrounding studies on properties of outcome measures. Okay, and specifically, we looked at 2 ways of looking at it. One is whereby you can use a critical appraisal test, which Kavi has put out for you. It's quite a simple one, where you ask several questions about whether the person has actually done this, done that, and whether they have actually, in terms of research design, they've actually done this, to be able to grade, to see how good the paper is or how good the research design has been, in order for you to be confident in making a judgment on whether we can actually use some of the statistics surrounding being produced by that paper. And then something more advanced, which is called COSMIN, which I know that is very difficult to use, and I understand that because I've actually looked at it myself as well. Now, that is a slightly more advanced level of actually looking at the properties and characteristics of our outcome measure. Not everyone will be engaging with it, because in order to use it, you have to have slightly more advanced knowledge about the theory surrounding how to produce a type of outcome measure or clinical measurement. So currently what we're talking about is classified under what's called classical test theory, okay, where these have been traditionally and conventionally used. But over the years, over the last 2 decades, there is a new theory that has been promoted much more, which is called item response theory, which if you read COSMIN, you realize that there are 2 separate sections for those. I won't go into that because obviously it's not within the remit of this particular module to cover that. But if you're interested, this is what the underlying theory surrounding a lot of clinical measurement and measurement outcome measure type development, what is going on. But the basic thing that I'm trying to get across to you is that we can and should assess the quality of the papers that we read regarding how we choose outcome measures. Why? Because if you don't, then any outcome measure you choose, you do not have a very firm rationale and foundation to give an explanation of why you've actually chosen it for that particular population that you're interested in measuring. Okay? And then when it comes, what will happen is, the worst case scenario is that you've chosen a wrong one or a bad outcome measure, and therefore everything you measure is wrong, and therefore you'll be wondering why patient hasn't improved as much as you like. It could be simply because you've chosen and not looked really closely at the outcome measure, whether it's relevant to your patient population or not. Best case scenario, if you've chosen a wrong one, you just carry on and just live as if nothing has happened, because sometimes people do. If I were to go out there in the clinics right now and look at some of the common outcome measures being used by the clinics, I would find several things. One is that a clinician is currently using outcome measures simply because everyone uses it, okay, because their boss tells them to use it. Or secondly, they're using it because they don't have time to actually do a proper search as to why the outcome measure is relevant. And thirdly, that particular outcome measure actually isn't that suitable for their patient population. Okay, so these are some common things that is occurring out there, and sometimes we wonder why our treatments aren't effective. It is not that our treatments aren't effective, but it's that we cannot capture our effectiveness good enough to be able to then determine that it's actually effective, which is why it's very important to choose an appropriate outcome measure so that we know that we are effective, not to be too egotistical, but we are effective in what we do because we can see plainly, physically, that the patients are improving. But how do we capture that accurately? That's why we need to choose an appropriate outcome measure. So far, do you have any questions for me in regards to what we covered in semester 1? So this is what you covered in semester 1. That's quite a lot of things to actually get your head around. But the main thing right now for you is, with all that knowledge in your head, you go, oh my god, what am I supposed to do now? Well, you're supposed to apply that now. Okay? For those of you who are full-time with us, you will be more of theoretically applying this to what you perceive to be your future clinical practice. However, if you are currently online with us, you most likely be able to apply this in your own practice right now. So let's move on now to the second section of this talk, where we talk about the most impending concern that you have, which is your assignment, part 1. Okay? Now, let me just remind you what you're supposed to do. The assignment is a 2,000 word assignment. Yep. And you're supposed to choose one clinical measurement tool or outcome measure, and you're asked to critically appraise its the properties of it. So the 3 properties are validity, reliability, and responsiveness, which is responsivity. Okay, so applied to a particular patient group or clinical population. Why have I put that last phrase, applied to clinical population? Simply because for a same outcome measure, when applying to a different clinical population, you can have actually slightly different properties. Okay, so you need to be able to determine that specific clinical group that you are interested in. Now, you would have already been asked to sort of have a chat with your assigned tutor as to what clinical measurement tool you are trying to, you will want to use, and whether it's appropriate or not. I would have corresponded either through email or through online chats. And so you should have something now. And what you should be doing, currently doing or finished doing, is collecting the literature surrounding the properties of that particular clinical measurement tool or outcome measure. Okay, so you should be you'll be doing a literature search based on what you've been taught so far on collecting the validity, reliability, and responsiveness of that tool. If you've already done that, the next thing you need to do is do a very quick appraisal of all the papers that you've collected so far, okay? Using the critical appraisal skills that we've taught you, looking at how good a paper is. Now, just to say that you won't be actually using all the information within the critical appraisal that you do. You only be using part of it now, and I'll sort of show you what I mean by you'll be only using part of it. But you should still go ahead and do the critique if you've got the time, the full critique, simply because it gives you an idea of how good the paper actually is, or how good the study is. Okay, and it also is a skill that needs practicing. A lot of students ask me, so how should I approach this assignment? How should I know what I should be doing? First thing, you need to read all the documentations that I've given you. Firstly, the guidelines. Within the guidelines itself, I've actually broken down the question for you and given you some of the key elements of what I'm actually looking for. Okay, so if you read the guidelines, you see there are actually more instructions within that. Beyond the guidelines, I've also published marking criteria for marking the assignment 1. Okay, I'm going to do that for assignment 2 as well. Why do I publish a marking criteria? Because I want you to know exactly what the markers are looking for. So what you need to do is download the marking criteria and look at the individual criteria to see what we are actually looking for. And I've given you a description for the different grades for that particular criteria. So imagine you are trying to, just looking at the C grade just for interest for that particular criteria. You know exactly what you need to do. And with that, you can then tailor your assignment and put in all the content that addresses that marking criteria. Okay? So I would ask that you download the marking criteria and then, looking very specifically at each criteria, tailor-make your assignment to address every single one of the marking criteria, because this is what we're going to use when we actually mark you. If you are able to address it adequately enough, that means that we can actually mark you quite high on each grade, and overall your marks will also increase. Okay. What's the end point of all this particular exercise? Is it just purely academic? No. We've deliberately designed this assignment so that it reflects what you might be thinking when you're actually choosing an outcome measure. Okay? So whilst you're doing that, essentially you are doing an exact exercise as a clinician who's choosing an entirely new clinical outcome measure for use in their own service for that particular patient population. Okay, so it's actually a real life exercise. So some of the skills that you acquire when you're actually doing this assignment is actually transferable to when you actually start practicing, or now that you are practicing. For the assignment itself, the 3 main areas that I said before that I need you to actually look more closely at, and that's validity, reliability, and responsiveness. So you should be geared towards those. I have deliberately chosen not to separate them into their different types, subtypes. The reason for that is because not every single outcome measure will have examined every single subtype. Let's say, for example, for validity, some may not have looked at discriminant validity. So what you need to do is collect as much as you can within the time that you have, and then choose the most appropriate validity types to report. Okay? Same for reliability. And you realize that for the newer outcome measures, there might not be papers for responsiveness. It's quite common. If that's the case, what you need to do is not to leave this entire section blank, because we still mark you on it. What you need to do is then tell us that there are currently no papers has yet been published on it. Okay? But tell us why it's important to actually measure and look at responsiveness, because this clinical population requires it in order for us to be able to look at improvements within a certain period of time. And tell us, if you were to be able to design a responsiveness study, what methodology would you use, and what is the time length you will be measuring based on previous literature where you know that the patients are progressing at a certain rate. Okay, so you know that if you are into that particular sort of discipline, you will be able to tell whether the patient would have an observable improvement by that amount of time. And that will be a sort of hint to you as to where to actually measure improvements. Okay, so you need to give us something even if there are no papers on it. Okay, this is essentially what we do when, let's say for example, when I choose an outcome measure for my own clinical practice. This is what I do as well, to look at all 3. If there's nothing there, then I would want to design something, or actually look out for papers that have got these characteristics. These slides will be available to you on the Hub at the by the end of the week when I actually upload this. So if you can't see the words on them, for those of you online, don't worry about it. You can actually have a look at it more closely. What I've done is I've actually broken down some of the basic questions you should be looking at within each particular characteristics of the scores or the outcome measures. So let's take for example validity. The very first question to ask for that paper that you are assessing is, what is the validity type that has been investigated for this outcome measure? So you may have collected between about 3 to 4 papers. Just look at the 3 to 4 of them, and see what type of validity they are actually measuring. A lot of times the paper will actually tell you what type of validity. If it doesn't tell you, then figure it out by using some of the definitions that's available online or within the textbook itself. Then, after knowing which type of validity you have, what you need to ask yourself is, what are the statistical values for the validity? They tend to use correlation coefficients. So is it high? Is it low? And then after you determine whether it's high or low, record it down, because you need those values. We will require you to put those statistical values into the assignment itself to show us that it's high or low or average. And then you need to interpret for us whether it's high, average, or low. Okay? Because that will then tell us whether how good it is in terms of certain aspects of validity. Next, you need to ask yourself, the patient population that has been used for those papers, is it relevant to your patient population? If it is, good. If it's not, then the first question to ask is, why am I collecting this paper? Or, if you feel that there is some relevance to it, but somehow or another it is a patient population that is similar but slightly different, then you need to say, well, how is it then generalizable from that population to your population? You need to think about that. Okay, it's something that we think about when we are choosing outcome measure in our clinical practice as well. Okay. If it's not appropriate, that was what I was saying, how can we actually generalize across? The same questions can be asked for reliability as well, so I won't repeat them, but instead of saying validity, now you're talking about reliability. For responsiveness, again, it's the same type of questions that you ask yourself. Okay, but for responsiveness, what you then need to think about now is, what are the approaches that the researchers have used to actually examine responsiveness or sensitivity to change within this? Because as I have shown you, there are different methods of actually measuring responsiveness and sensitivity to change. So in order for the reader or the marker to be able to know how they come to that particular value, they also need to know the approach and the method they come to measuring responsiveness. Okay. So, to summarize in terms of what you want to do for your assignment, essentially go read the guidelines very carefully, and also to look at the marking criteria. And if in doubt, you always got your assigned tutors to refer to, and that's what we're there for you for. So email us or arrange a meeting to meet us. Okay, that's why we set up weeks where you are allowed to actually contact us. Okay, just to chat over some of these issues that you're having. So, with that, do you have any questions for me? No? You sure? Have I answered all your questions?
I was thinking about an example. Can you give us an example of?
Example of?
Of the assessment, how, I don't know, like a title or something, guide us. I don't know.
Can you sort of explain this a little bit more? I don't understand.
Yeah. Like, how can I say a title? For example, the title that we have on an assessment, how it will be in order to guide the reader what we are writing about. And
it's all written in the guidelines,
okay.
as well as the marking criteria.
Oh yeah.
It should all be there. I've actually explained out quite clearly to you what you should be including into your. I mean, obviously, I cannot write the thing for you.
Yeah.
Yeah. So, but what I've done is I give you very broad questions, and the reason why I give you broad questions is because I don't know what outcome measures you've chosen and what areas you've chosen. But the questions I've asked you in the marking criteria will then show you exactly where to aim for. Okay? Within the guidelines, I remember, I think I've given you subtopic titles where I've asked you to use these topic titles to frame your paragraphs. So maybe that will help you to think about what it is. I mean, the three very obvious topic titles are validity, reliability, and responsiveness. And then within that, you need to then break it down in terms of the questions that are actually posed to you and put that in. Always remember that anything you say needs to be backed up by a citation. Let's say you're talking about a particular study. Yeah, you are talking about its reliability. You need to then quote that particular paper and put it down in your reference list. That's quite common practice.
Yeah.
Okay, so beyond the three main topic titles, what I think I've suggested is at the very beginning you also say why you've chosen the outcome measure for your context, and what is the patient population that you've chosen for, and why do you think that this outcome measure might be appropriate. Okay, so you then have to think very hard why you've chosen the outcome measure. You can't just pick an outcome measure randomly and then match it to a patient population, because that just doesn't work. You have to think of why that is important. Okay? And I think towards the end, you can then conclude, based on what you've found so far, how good overall is this outcome measure based on what you have discovered about its validity, reliability, and responsiveness. Is it good enough for you to use in a clinical practice, or do you think it needs a bit more improvement in terms of certain areas before you can start using it? Or is it just not good enough and you may have to search for something else? It's okay to say that it's not good enough and you need to search for something else to actually use it in a clinical practice. It's fine. That is a solid conclusion as well. So you've got three types of conclusion.
Yeah.
Can use, maybe, but needs improvement, or can't use.
Yeah.
Got that?
Yeah.
Good. Any other questions for me? No?
I'm good.
You're good. Okay. We shall see. What we can do is, can I encourage all of you to actually contact your assigned tutors? So because if you have further doubts, the best thing to do is just chat it over with your tutors. Then they can, because they will know your individual topics much more intimately, because you have consulted them as to what's going on, and then they will be able to give you a bit more information related to the topic that you've chosen. Is that okay?
Yeah.
Good. Right.